So Dr Chris Bollen is a general practitioner at Oakton Medical Centre, South Adelaide, and was a Director GP training at Queen Elizabeth Hospital for 12 years. He also is also a Director at BMP Healthcare Consulting, a management consulting company helping organisations deliver safe and effective healthcare. Areas of expertise include systems for chronic disease management, doctors' health, care for older people, the primary health care, community hospital interfaces, quality improvement and change leadership. It's always a challenge. He is currently Deputy Chair of the RACGP and South Australian Northern Territory Faculty Board and has previously been Treasurer, Chairperson and CEO of several dynamic healthcare organisations. Other current roles include membership of the Australian Commission of Safety and Quality in Healthcare, Clinical Communications Advisory Group, the Primary Care Education Advisory Group for Kidney Australia, called the PEAK Committee, Arthritis in South Australia's Education and Research Advisory Committee, and Medical Advisor to Return to Work South Australia. Wow, fantastic, Chris. Thank you so much for joining us today, and we really look forward to your presentation.
Right. Thank you, Kathy. Right, well, thank you all very much. Some of you have been to some sessions maybe that I've run in previous years. Who's been to some of the sessions in the past? Fantastic, great to have you back. So I'm not going to do every single piece of a 75 health assessment, okay? 90 minutes, never long enough. What I really want to look at is what is going to truly make an impact. And so just before we make an impact, we need to make sure that this is running. Okay, here we go. So I thought I'd put the big car. That's what we're going to see tonight. How many of you have been to Mona in the past? Okay, so the Big Ferrari that's been fattened up just to reflect on what's happening in life. My little reminder for you actually to think is that when we're dealing with older people between 75 and 105, and they actually are obese, it doesn't mean that they are either undernutritioned or not frail. In this day and age, obesity in older people masks many issues. So we've always been trained to think, oh, the thin BMI less than 20 is the one we need to focus on. That is no longer correct. So that's my little thinking there. Now, basically, we're just going to talk a little bit about this rundown. We're going to talk why do we need a session on improving 75 health assessments. We've got a case study about Mrs. Andrews, and the big sort of emphasis today will be looking at the issues relating to frailty. This is a take-home message now. I like to do that first up so you can take something away to remember. So we're going to have 5 M's, that's why I've got the M&M's up there, 3 D's and 1 F. So those 5 M's are really, and this comes from effective care of older people, improving health systems in older people, the Hartford Institute or Foundation in the US, and I've actually added a couple of things here, but really getting you to think about what matters to older people. We need to think about mobility, medicines, their mentation, and the 3 Ds below that, malnutrition, and the frail screens. So if your health assessments can have that in there, you're going to actually have a much greater impact. Now, why this session? Well, I think we all know we've got a few more older people in our communities. How many of you here are working actively with older people? Good, okay. All right, so on the screen here, hopefully that, right, this is what's happening with people over 80. Our practices are changing. The population over 80 is expanding very rapidly. More of them are living at home. More of them want to live independently and well at home. But one of the things that's happening is, that's a hospital there. It's basically overflowing. And the research of the last decade shows that the 80-year-old plus group are spending, on average, 8 days longer in hospital than their under 80 cohort. They have a lot more bed days compared to their under 80 cohort. But this really important thing is the number of health professionals with no geriatric or geriatric training is increasing at a rapid rate. So the gap between the community that most needs the extra care and the health professional workforce skills and knowledge is increasing at a rapid rate. So how many of you here have had formal geriatric nursing or healthcare training in your lives? All right, so the majority of the room is working with older people. Very few of you have had formal training to actually, make sure that you're up to date and with the skills. So, it's one of the big things that throughout the whole healthcare workforce world, this gap exists. So, very sad for all of us that are getting older. So, we're here to make a difference. Okay, now, we've got a board here. Now, there's some learning objectives I set, but you're here, you've given up your 90 minutes today. What is it you really want to know about today? So just give me a couple of learning objectives that may not be up there and see if we can work with them. Okay, shout it out. Oh. Why is it useless? All right. Okay, we'll see if we can come back to that one. The fact you're actually asking it is important. A lot of people don't ask. Falls prevention, okay. I'm glad you mentioned that one because that's an important one under the mobility. All right, one more. Okay. All right, we'll see if we can get onto that. Okay, so there are some things that, so basically depression is under mentation, falls prevention is under mobility, technology is something we can cover. Okay, so I'm going to introduce you to Mrs. Andrews first because why we're doing what we do in primary health care is to improve the life of older people, keep them well and independent at home. That's really essentially what it is. I'm going to run you through Mrs. Andrews. I'm going to ask you what you think about Mrs. Andrews, and then we'll frame some of what we do after that. Because essentially, if all of us in this room are not getting it right for Mrs. Andrews, then essentially what hope has our healthcare system got? So I'll leave you with that and we'll play Mrs. Andrews.
My name is June Andrews. I'm 84. This is the story of my trip to hospital. It started one Friday evening when I had a fall in the bathroom. My husband called the out-of-hours doctor, who told us to call 999. Arthur couldn't help me get back up on my feet. I had a nasty bruise over my right hip. I wasn't keen on coming into hospital, but they persuaded me.
I was on call when Mrs. Andrews was brought in, and I arranged a hip X-ray. There was no fracture, but some blood and urine tests showed that she was a little dehydrated and had a possible water infection.
Mrs. Andrews was moved on to the acute medical unit. She was getting close to breaching the 4-hour target. It was also getting late, and the AMU was a safer place to assess her and get her back on her feet. We put up a drip and gave her some antibiotic tablets for the urine infection. On Saturday morning, she was seen by the on-call medical consultant. Before we could look at her mobility, the patient flow team insisted we move her to the first available medical bed. She was not reviewed again medically till Monday. There is no routine physiotherapy or occupational therapy over weekends, so we couldn't refer her to the home rehabilitation team before then. By Monday, June had been on either a trolley or in a bed with the cot sides up for 3 nights because she was deemed to be at high risk of falls and the nurses had inserted a urinary catheter. She was seen that Monday morning by the physiotherapist who got her out of bed with the aid of a Zimmer frame. My home ward is in the elderly care unit. We do our best to provide a regular liaison service to other wards, although we wish the doctors there had more knowledge about managing older patients. The ward doctors and occupational therapists made a plan to get some more information about June's usual abilities and past medical history.
I'm June's husband. On Monday, I was able to get back into the hospital to see her on the ward. I told the ward doctors and nurses that June had been getting more unsteady recently, had suffered another fall, and that her memory isn't what it used to be.
The review team discovered that her blood pressure was dropping very low when she stood up, postural hypertension. It often leads to falls and faints in older people. We stopped a couple of her cardiac medications to try and solve this problem. By Wednesday, she was able to stand with assistance. The physios came to see her, and a plan was made to refer her for ongoing rehabilitation in the local community hospital before going home. But not for the first time. There were no community beds, and by the 10th day of June's admission, the cardiology ward desperately needed beds for acute cardiac patients, and she was moved to a winter escalation ward. After all those moves, Mrs. Andrews had become confused and agitated. She had another fall, sprained her wrist, and now she required 2 nurses to transfer her from bed. June spent increasing time in bed with the cot sides up. By day 12 of her admission, the community hospital phoned back saying that she had no rehab potential and should have a care package instead. She was referred to social services with a target discharge date for Friday, but the package couldn't be put in place till the following Tuesday. She went home with a 3 times a day care package, but with no clear diagnosis for her progressive memory impairment and falls. 7 weeks after her discharge from hospital, June had fallen twice more. Her memory was worsening, and Arthur was becoming stressed, concerned, and exhausted. June ended up being admitted for respite to a local care home. Mrs. Andrews never got back to her own home after her respite. We should have more care and support for older people like her outside hospital, and those services need to respond much earlier to people's needs. But the way we treated her in hospital and our difficulty getting her back on her feet and home again didn't help. With so many frail older people coming into hospital, we have to get this stuff right for everyone.
Okay, so is Mrs. Andrews a rarity? No. So if Mrs. Andrews is not a rarity, there's a lot of discussion about 75 plus health assessments currently about they offer no value for older people. So a interesting study that came out last year by Karen Grimmer, who's got a big interest in older people, interviewed older people that were having health assessments. The big question that she put to them was, did they feel that the health assessment they had with their general practice was delivering a message that could help keep them well and independent at home? And overwhelmingly, the focus groups of older people said no. They felt that this did not actually help them in any way. Now, it was only a small study of about 5 or 6 practices, and so clearly none of you were at those practices because you're all doing a fantastic job. But what it means is that we need to really be clear that if we're going to deliver the health assessments, we need to ensure they have an impact and that the older people are actually engaged and activated to think about doing something different. Because you're getting a lot of information in your health assessments, but is it actually being acted upon by, well, one, yourselves, you're picking things up, but are you doing anything and referring places? Are the doctors that you work with actually reading the health assessments and actually doing something differently? And thirdly, are the older people getting a copy to take away so they can share that with all of the other multiple providers in their lives? How many people can say 100% of the time that happens? Yeah. And look, I've done a lot of research reviewing older people that go to hospital. They're in the EDs, I go back to their practices, I review the health assessments, I review the case notes, and basically what we find is a lot of older people that go to EDs on a recurrent basis have not had a health assessment, do not have a care plan, and if they have had one, a lot of information is not being used or it's not being picked up, the fact that they have early dementia, that they actually have a greater falls risk through something called frailty, which we'll talk about in a moment, or they actually have, they're undernutritioned. And so all of these things make a huge impact. If we're not picking up the right stuff, then we can't make a difference to older people. So Mrs. Smith and Mrs. Andrews are, clearly related, aren't they? Mrs. Smith here is part of the fragmented care chain as well, that she visits many, many people, and she has to repeat her story to every single one of them. Now, if she was like Mrs. Andrews and has some memory changes, and especially, I guess I was very interested in Mrs. Andrews who had progressive memory loss. So what immediately should you be thinking about for someone who has progressive memory loss? What was the D word? Dementia, that's right. And so dementia is a progressive neurological condition, so it needs to be picked up early. But it doesn't get picked up very well at all. So if you've got some cognitive change, you're on 10 medicines, and you go to all those providers, what is the likelihood of accuracy of transmission of information between the consumer and the provider? No. So it all falls apart. That's where one of our issues is with the fragmented care chain. So going back to technology, so I guess that's the importance of having a My Health record for Mrs. Andrews, Mrs. Smith, and Sam, who we'll meet a little bit later. So it's critical that they are the ones that you get the uploads occurring for. Now, so we need to think about doing stuff differently. Now, because this little story is important because it's about a geriatric unit in Thomas and Guy's Hospital in London. And that was me going through a simulation. And this is the ageing suit. Now, the story at Thomas and Guy's was that they thought they were pretty good at managing older people. A bit like the previous Mrs. Andrews. But what they then did, they did a survey of patient satisfaction, complaints about the care that was actually being received. And this is on the back of the mid-staff inquiry. How many of you are aware of the mid-staff inquiry? Yeah, so it was really a big issue in the NHS about poor care on many levels, and older people were the major recipients of poor care. So the Thomas and Guy's team said, all right, we need to get a bit of a survey. What do older people think about the care? What do their relatives think? And they got a bit of a shock. They found lots of complaints, lots of concerns. They weren't delivering patient-centred care. They had, there was lots of dissatisfaction. So any good improvement model reflects on the data. Okay, in this case, the data was the complaints and concerns. We can do better. What can we do differently? So what they then had a look at was the patient-centeredness of what they did was no one seemed to really understand the patient journey and the patient experience of being older and in a public hospital. So what they then did was they created the simulation lab, and every person from the cleaner to the consultant had to go through the simulation lab with the ageing suit on to experience what you can see. So these were gloves with metal mesh to simulate arthritic hands. These are basically metal sort of impregnated sleeves that are velcroed on to actually reduce your mobility. With the knees, on the side here, this is a way of making my back stiffer. I've got goggles on, which have actually narrowed my vision, and I was required to actually go to the toilet to actually try and use the taps. I had to be fed by someone, and it was a really interesting experience because all of a sudden you go, holy shit, this is not a good situation to be in. Now, so that was their simulation, and every new doctor, nurse, admin person in that unit has to go through this as part of their induction. So what happens? They then repeat their survey, and they top the hospitals in the UK on patient satisfaction and patient-centeredness with using this approach of getting people to really understand the real issues behind their consumers in those units. Made a really big difference. So it's about thinking differently. What they did was they used their data, used their feedback to go, we've got to change. We've got to do something different to what's happening. So it's a message for all of us that we can't be complacent. If we're getting feedback, going back to Karen Grimmer's discussion about what do people think about what we do as a profession, doctors and nurses in primary health care, about the health assessments that we're doing. We need to think differently and make sure that we have higher impact. So, what are our barriers then to recognising Mrs. Andrews in our practices being frail? So, take a few moments talking at your table about whether you even know what the concept of frailty is and what your barriers are professionally and personally to actually recognising frailty. All right, I'll give you about 2 minutes. Let's hear, you've a lot of discussion there, so let's look at what are some of the reflections on why it is that Mrs. Andrews, who was clearly frail, why it was that if we'd been in our practices, why it was that we didn't recognise Mrs. Andrews as frail. So I'll go around and get some table feedback. What's a big reason? Okay, yeah. Okay, good. So the big question. Good, thank you. Next table. What's a barrier to you recognising it? Time. So why is time a barrier for you? Okay, so the people that are most acutely unwell are often not getting the proactive preventative care. Yep, okay, good. Acute versus prevention. Okay, thank you. Next table. So, yes, so you're right, Jane, that they clearly don't want to admit that they are in that situation. So they have their lippy on, they've had their hair done, specially come and see you. Yeah. Yeah. No, especially when they come along for their driver's licence medical. Yeah. No, so good. Thank you, Jane. Table at the front in this area. Yeah. So the interdependency. That's right. So strengths and weakness, they offset each other. Good, thank you. Hand at the back. Yes. Okay. So different eyes all the time. So that fragmentation. Okay, thank you. Corner, table. Oh, actually, that's interesting you say that. So that doesn't always have to be only because you see it at home, but yeah. Yeah, okay, so home versus surgery or office. Okay, thank you. Next one. Good, good. Okay, so what is asked? So if you don't look for it, you will not find it. And this table? Information sharing? Yeah. So Mrs. Andrews has been in hospital. She might have had a physio assessment, an OT assessment, but did we get it out in the community? No. Okay, so sharing. So good. So lots of barriers. All right, so I'm glad the number one question is what is frailty, because that's what we're going to work on next. And essentially, in a relatively short time period, because it's a really important concept. It's really well understood by geriatricians. There's lots of research happening, but the big but is there's lots of controversy over it as well. But essentially, what we in the community have to know about is it exists, there are evidence-based screening tools, and you can do something about it. It's not just about you can't do anything because you're getting old, love. It's just not going to cut it. We've got to be much more proactive with our older people. So what frailty is? Multi-system impairment associated with increased vulnerability to stressors, and essentially the big issues are that we've got weight loss, low grip strength, exhausted, I'm tired, low physical activity, and we walk slowly. So all of these things you see, but you've got to put them together to actually understand this is frailty. So it's not one condition, it's multi-system. That one there is by Linda Freed, and there are many different scales, and don't worry about this one specifically, because we'll come to one that's easy to remember later, okay? But it's just getting in your head that, you know, if you've got an older person that's losing some weight, 5% of their body weight in 6 months. The gold standard is you should weigh a person 75 and over at every consultation. Gold standard. Because otherwise, you will miss this. Low grip strength. We'll talk a little bit about what that might look like. And doesn't mean an arm wrestle. All right. Sarcopenia. How many of you know what sarcopenia is? Okay, so basically it's the loss of muscle mass. It's a really important thing to understand with this concept of frailty, because essentially we all lose it as we get older. And Mrs. Andrews, really importantly, she was in hospital for a couple of weeks. So she went in frail. What happens when she's in hospital for 2 weeks? What was that? Yeah, and what does that do? She loses strength. She loses muscle mass and strength. She loses 10% of her strength every week that she's in hospital. All right, so that's a really important factor. That if already she has already some increased vulnerability, you lose more muscle mass and strength, your vulnerability just keeps on increasing. And it's often forgotten. And so on discharge, they don't get, that older person like Mrs. Andrews doesn't get that extra exercise program that is required. Okay, so Linda Freed, a geriatrician and epidemiologist from the US and Canada, essentially has looked at these stages of frailty. So there's healthy aging, going along like that, and then we get older, but then we become chronically vulnerable, and essentially our rate of decline, because unfortunately after 50, it's all downhill. I know, that's right, and look, there are a couple of us in this room that might be in that area. So, but, it's important to think that more of us are going to get to 100 than ever before. So we've got to do something positive to get there. It just doesn't happen. And so that's one of the take-homes for all of us as individuals today. All right, so basically, we decline, we have an acute illness, and then suddenly we lose our capacity, mental and physical. Mrs. Andrews is a great example. What are some little things that might cause someone who has chronic vulnerability to suddenly drop like a stone? Pneumonia is a big thing, but what's something little? UTI, exactly. How often do we hear about the febrile older person that had a syncopal episode brought in by ambulance, had a fall and broke their hip? All right, little thing, domino effect, bang, down they go. That's what frailty is all about. Little things that we would normally think a fit, well, older person could withstand. Their system is under duress. They are chronically vulnerable to the little things that matter. Okay, and then putting it in a linear fashion, this is basically focused on our older style home care packages prior to consumer-directed care. So essentially, the very fit through the terminally ill, home support services and the various home care packages are focused in this sort of area. Now, if we can actually recognise people in these mildly to moderately frail areas, we can actually improve their ability to live a better life. Clearly, down this end of the spectrum, the ability to make changes may well have skipped past the post. So, but you can still do something, but this is where the bulk of preventative work can actually make a difference. Now, another definition of frailty, Ken Rockwood, another researcher, he has a very complicated frailty scale with about 60 items. Great for researchers, not great for us who are time poor. And so it basically says, look, it's a combination of natural aging process and a variety of other medical problems. And he focuses on this definition: the loss of reserves, energy, physical ability, cognition, and health. Really important, because the other one sometimes doesn't look at cognition. And we think about the frail body, frail mind concept. We'll see that quite a bit in our practices. Now, this nice little slide comes from a guy called Professor John Young. He's a geriatrician in the community in the UK. And what's interesting about this is that, you know, he gives us such a positive outlook here, doesn't it? Bad news, it's not a disease. Some more bad news, it affects the whole body. Even more bad news, every person that we're going to see in our practices is different. And the worst of news, lots of things can go wrong at once. So essentially, he's the bringer of good news, that this is beyond our usual methodologies of understanding what we can be doing, and guidelines are thrown out the window. And, you know, majority of what actually occurs for the care of older people is actually no longer guideline healthcare. We've got to actually individualise it because of the dilemmas. So I'll come back to that in a little moment. So why do we worry about frailty? All right, so on this side, we've got all the symptoms, and so many of our older people have those, don't they? And this are the adverse effects: the falls, the injuries, the hospitalisations, dependency, and it doesn't have a great future. So picking it up is important. And this is just another way of getting to think about it. So here's our independent state. We have a minor illness. It has an effect on our overall system. Drop off, little drop off, back to being a level of function. All right, here's the person that's at risk. UTI, bang, down into the dependent area, like Mrs. Andrews, and slow recovery. If you're lucky, you get back to being functional, but never the same as what you were. So that's a real snapshot of what we need to think about, is picking up the Mrs. Andrews and doing something so we can improve their resilience. So we understand about the loss of muscle mass. Frailty is a slow process. Lots of increments of decline. The acute events can make it worse. Importantly, when it comes to understanding it, the abnormal function, inflammatory and neuroendocrine systems is really important. And the changes in our whole immune system mean that, and a good example is to think about why is Zostavax, the shingles vaccine, now listed for giving for people 70 to 79. Because 1 in 2 people age 80 to 105 are likely to get shingles. And what happens when that older person gets shingles, especially Mrs. Andrews? They go down in a heap. And many of them become institutionalised as a result of something like shingles. When they were 40, it's a nasty illness, you get over it, and you get back on your horse. Mrs. Andrews, if she gets shingles, not going to do very well. So it's a really important one to think about in your health assessments, ensuring that you capture that 75 to 79 group and getting that shingles vaccine sorted, because their future it depends on it. Now, this complex little side is an important one just to get your head around when it comes to frailty. So there's the loss of muscle mass. What does that actually do for us? All right, so it reduces our VO2 max. So that's our ability to actually be efficient at using oxygen in our activities. And so the less efficient we are, the less fit we are, less aerobically, and it's more of an effort for us to do stuff. We lose strength and power. Our resting metabolic rate goes down. Our walking speed is reduced. And then if we happen to have osteoarthritis of the knees or hip, something else that's another disability that actually causes us to have a problem, that then compounds it because our activity is going to be less. If our activity is less, we're going to be sitting around watching telly more, and our energy expenditure is going to be less. The anorexia of aging starts setting in as well. Chronic undernutrition, because if we're not as hungry, we're not going to be eating as much. We're not getting out as much is a big link between undernutrition as well. And as that all happens, we've got the more skeletal muscle changes. We've got, if we're not taking much protein in, we're chewing up our own protein, which is in our muscle. So we reduce our muscle mass again, and the whole spiral just keeps on happening. So that's essentially what's happening as we're getting older. And for the frail person, that's happening quicker than others. And the fundamental part is to really increase our muscle mass to actually make a difference. So with our muscle mass, in our early life, we have a certain amount. So genetically, we're predisposed. Our nutrition as youngsters. In our adult life, we need to try and maintain it. And so some of us drop off quicker than others with the amount of muscle mass. So when we get to older age, then some of us start here and some of us start here. And so you can see the decline of muscle mass is greater at the lower levels. Really important for all of us that are over 50 currently, because we lose 1% of muscle mass per year after the age of 50 and about 2% after the age of 65. So here's Mrs. Andrews when she was 25, and here's a 75-year-old Mrs. Andrews, and look what's happened to her muscle mass. It's just a nice CT scan of the thigh. So where is it? How big an issue is it? Currently, it's not recorded. I understand in best practice, you can record frailty as a long-term condition, but in many other software programs, you can't. In hospitals, it's not often recorded either. Now, this is the really important thing, because if older people want to be independent, we go back, if that's Mrs. Andrews, well, clearly she's going to struggle. Now, that's what we'd like to be seeing, because people want to stay in their own home. They are adamant, aren't they, that that's a secure, happy place. Now, so our task is to actually ensure that as many Mrs. Andrews, they may not be lifting what essentially could be about 60 kilos there, but what I'm getting at is that we need to be thinking about exercise programs for older people as a real positive. The clinical frailty scale is something some of you may have seen. Who's seen this before? So essentially, it's just a silhouette way of being able to pick who might actually be at risk. So there are lots of different ways of screening for this. So here's vulnerable, and the big issue here is going back to, we've got a stick, so our walking speed's going to be slower. We've got another walking frame, so we're going to be more frail. Moderately frail, we need more assistance to do things, and clearly severely frail, we're not able to walk far at all. So screening for frailty needs to occur at every interaction with a person over 70. All right, it's not a general population screening, but if you're an older person using a health service, then a frail screen should be used. Which ones are right? Well, there are about 200 frailty screening tools. What does that tell you if there's 200? There's a lot of debate and confusion about what it all means. So I like to keep things simple, so I've just brought two for you today. And number one, I'd like you to actually think of, we'll do the little case first and think about what this might mean as far as a frailty screen. So we've got Sam, he's 86, ex-farmer, looks as though he's well-nourished, and he's got a medical history of multiple things happening to him, including arthritic knees and some mild Alzheimer's disease. 60-year history of tobacco use. What immediately should you be thinking about? That is, if a bloke like Sam has had 60 years of smoking? That's right, COPD, major undetected area in older people. They're not even on his medical history because no one's actually looked for it. It's a major reason why he will be slower. His VO2 max will be less because he can't get the oxygen in. So there's a whole lot of important things that aren't being said about Sam, but because you're clever, you know about COPD. Now, all right, so what would we look at for Sam that can help us think about could he be frail or not by definition? Yep, so we want to know about his weight. Sorry? Mobility, that's right. So he's got OA knees, he's actually walking with a stick. So what's that going to mean about his walking speed? Slow, yeah, okay. All right, so PRISMA. Basically, this is a Canadian screening tool, and it's widely used in the UK. There's a wonderful publication called Fit for Frailty put out by the British Geriatric Society, and essentially they have worked with the College of General Practice and primary care nurses in the UK to put this publication out. And great website, so Fit for Frailty. And they recommend using the PRISMA, P-R-I-S-M-A, and it's an acronym for the M and the A is for maintaining autonomy. Don't worry about what it actually means, but it's about if we can pick up people who are frail, do something different, we can help them maintain autonomy at home. So essentially, if you can't, can you read that at the back? Okay, so let's look at Sam. He's over 85, yes? He's male, because good old males, we unfortunately are more likely to be an issue than females. In general, do you have any health problems that require you to limit your activities? Yes, his arthritic knees limit him. Do you need someone to help you on a regular basis? Yes. He has his wife's at home. In general, do you have any health problems that require you to stay at home? Yes. Because he has some dementia, he doesn't get out nearly as much as he used to. Case of need, can you count on someone close to you? Now, this is an interesting question because if you answer yes to these, that's a point that adds up. Now, why are we saying in case of need, can you count on someone close to you? Yeah, and so why is that a marker against you? Because it's counterintuitive, isn't it, as far as a question? Yeah, so it means that you've already thought about what happens, and I need help, and I've got someone to call. So it's about thinking, okay, their autonomy is at risk. That's why it's there. And you regularly use a stick. So essentially, he scores probably in that. We look at that. He's got a 1, a 2, a 3, a 4, a 5, a 6, and a 7. So he's clearly frail. But what I'm just using that as an example is that there are a lot of people that come into your offices that aren't there, that you see at home, that are like Sam, that you will not have picked up as being frail. And so what that means is that Sam, with his dementia, his arthritis, his hypertension, you know, he's strictly following his diet for it to reduce his lipids, and he's a good boy. He comes along every 3 months and wants his lipids checked, has his blood pressure checked. He's very, very happy that he's got good blood pressure control. Are we missing the point? We are missing the point because basically, based on frailty, I'm going to show you a slide soon, that walking speed is a greater predictor of poor outcomes than blood pressure is in the 75 to 105 group. So here he is, he's being very concordant with his diet, his blood pressure control, but he's not actually having his function improved. So that's the big message to take home today, that we need to focus on function, not disease. And he's getting all the wrong messages. Now, this is a really easy one to take home. It's the frail screen. Some of you might have seen me present this before, but it's F-R-A-I-L. And I'm a simple soul. I like to keep it so we can remember it easy. F is for, are you feeling tired and worn out? R is resistance. Can you get your body weight up a flight of stairs? A is for ambulation. Can you walk around the block? I have 5 or more illnesses, and L is that loss of weight of 5% or more. So this is from a bloke called Professor John Morley from St. Louis, and he's a geriatrician with a big interest in putting evidence-based healthcare for older people. And so he's actually, this has been used and validated multiple times. And so it's really worthwhile having in your toolkit, FRAIL. And remember, it's a screening tool. And so the importance of putting this into a health assessment or into a care plan appointment with an older person is that you are screening to see whether we need to do anything more. That's really what it's saying. And so if you're scoring 2, pre-frail, and 3 or more means red light are on, we need to be doing something different. So are our health assessments containing objective measures? Because even though we've talked before about are we asking the right questions, are we also doing the right tasks? Because it's not just about ticking some boxes. It's also about what are some objective measures. So when we look at frailty, one of the really important objective measures is walking speed. So how many of you do a 4-metre walking test when you do your health assessments? Okay, all right, that's probably the single most important thing you can actually do in a health assessment. If mobility is one of the biggest concerns of older people, then we need to respond by understanding their mobility issues. If we're not measuring their function, we will not deliver value to them because we won't then be able to act on anything different. So a 4-metre walking test is very straightforward, and I'll show you a picture of it. But what we've done in our surgery is essentially got some of that black and yellow tape, which is like a warning tape. You put it at various markers along the wall, and you use your stopwatch or your iPhone or your wristwatch and measure how long it takes for that person to walk that distance. The other most really important one is the timed up and go. How many of you are using timed up and go? Okay, it's not the breakfast cereal. Okay, so timed up and go is the other really important test that you can do. And there'll be a picture up in a moment that you can take a photo of. But essentially, it's about getting a person... I haven't got a chair here. Kathy, would you like to demonstrate? Come up to the... just pop it up here. Okay, have a seat, Kathy. This is our 88-year-old Kathy Godwin. All right, so we've got 3 metres, so we either have a little cone or an object. Kathy, I'd like you to get up out of the chair, walk around me, and then sit down. I've got my stopwatch on. Boy, she's good, isn't she? Okay, fantastic. Okay, bang. All right, now I've got some bad news for you. That took you 12 seconds. So that's 10 seconds is the cutoff for the timed up and go. So it means that we need to be doing something different, Kathy, to help you keep really well at home. How important is keeping well at home to you? Haven't thought about it. How many of your friends have gone into care recently? Yeah. Well, I'm feeling a bit worried because you know that you're slowing down a little bit. Yeah. Okay, wait. So that is the timed up and go, and a really important test. Kathy? 3 metres. 3 metres. There are various versions, but the 3-metre one is something that you can do in your rooms or when you go to see someone at their home. Okay? All right, thank you very much for demonstrating, Kathy. Okay, and then we've got the grip strength, and I'll show you that in a moment. So that is a really good thing. This thing here, the Toolkit for General Practice Frailty for GPs and nurses in primary care, it's the 2017 version. There was one in 2014, but if you actually go to that URL, there's a fantastic book, which is really a guidebook for helping us in working with older people. And unfortunately, we don't have anything, from a national perspective here in Australia. Okay, going back to the walking speed. So essentially, this is some of the evidence. This thing called the SPRINT study in Europe currently is looking at this. And so vital signs, we do blood pressure, pulse, temperature, oxygen sats, respiratory rate. Why aren't we doing walking speed if we know the evidence says that's a fundamental indicator of outcomes for an older person? Okay, so this one looks a little bit about grip strength, big links to fracture and cognitive decline, walking speed, high risks of fracture and cognitive decline, the chair rises, which is basically the chair and try to do as many sit to stands in 60 seconds. And if you are a low number of those, it's an indicator of things aren't going to be good for you. Now, this is the grip strength. How many of you measure grip strength in your practices? Fantastic. Someone does. Oh, I'm so relieved. What was that? Not for older people. Wow. Who are you doing it for? Staff. Young people. Oh, okay. Bodybuilders. Good. Okay. So one of the reasons this is important is my geriatrician friends challenged me, said, Chris, how come you do not use these wonderful dynamometers to measure grip strength? Because geriatricians do it all the time, exercise physiologists do it, many physios do it. And I said, well, how much does it cost? Oh, between $400 and $1,500. So I cynically said, there's no item number for that. So that though got me thinking, what can we do in general practice that is low cost that I could actually give to each of the treatment rooms where health assessments are done in our surgery? So on eBay, I found this one, $25. It's simply a screener, and what happens is, if you are, for a male, 30 kilos or less, you are weak by definition. If you're a female and you are 20 kilo grip strength, you are weak by definition. That means the red light must be flashing, you need to do something different. It says your muscle strength is low, we need to activate to increase your muscle strength. So what we need to be doing is recognising it. And if we don't recognise it, clearly we won't have the right conversations. So the walking test, if it takes you more than 5 seconds to walk 4 metres, then you are frail by definition. Okay, so the walking speed is critical. Now, how do you do it? Now, this is the one that you want to take a picture of. So we have an acceleration zone of 1 metre. So that yellow and black tape is the 0, then we've got 1 metre marked. Why do we have an acceleration zone for older people? Pardon? Correct. So, and they're not even in a chair at this stage. So what's a condition? Fantastic, that's right. So that's slowness to initiate movement. So get them going, or they've got their frame, they get moving, bang, stopwatch on. Okay, 4 metres, bang. Do that and then walk back again and repeat the same thing. Take the average. Essentially, if they are 5 seconds or more, that means frailty has been recognised. We need to be changing something. Okay, timed up and go we've talked about. So if you want to take a picture of that, plenty of videos and other things on Google. But essentially, if it's more than 10 seconds, then we're going to do a full assessment to look at your whether there's a problem with postural blood pressure, any other sort of issues which might actually be causing you to be walking slowly as well. Okay? Right, so why are we doing these things? So why do we do health assessments? And so it's really about picking up things early, isn't it? Being proactive. But overall, there's a low take-up, less than 20% of older people. There's people are struggling to show the evidence for impact, and clearly the Karen Grimmer article is also a concern. Are the templates that you use actually fit for purpose? No, they're not, are they? That's the really big one. And what are the barriers for older people? How many of you actually have success in enticing your older population to have health assessments either at home or in the surgery on a regular basis? Okay, regular, good, all right. How many of you see it as a real struggle, though, to get them interested? Okay, so there are a whole lot of hands that didn't go up there. So it's about what we're actually, what's on offer, and that's the really important part. How engaging are we as practices to say, we're here to deliver great care, we want to work with you as older people to keep you independent at home? How many of you actually have really interesting flyers that would motivate you, your 80-year-old selves, to come in and have this done? No hands have gone up. All right, we've got to, okay, and you've, it's really much, because a study of a whole lot of practice, I've been, a media department. Where are you from? Right. Well, who's got a media department? Yeah, okay, so, but clearly, what we need to understand, so user experience design, how many of you know what user experience designers are? That basically, they understand, they're people that work out, is the message right for the audience? So older people need the right messages to activate them to go, I'm going to come and see Kathy's practice because, she's got something that I value and it's going to help me keep really well. So we need to look at the marketing that our practices have, because the majority of practices that I've seen, if they do send something out, it's a letter. Dear Kathy, Dr Bollen would like you to come in for a health assessment. Please ring reception to make an appointment. That's really going to get me motivated, isn't it? So we need to be doing something a bit different. Yes, marketing person?
I personally feel that only nurses and staff should be asking the patient whether they would like one. Because I personally was asked 7 times by the secretary, would I like a 45 to 49-year-old health?
What, that you were rung up?
No, just every time I presented, obviously there were reminders there. He hasn't had it.
Oh, well.
That really ticked me off, and I thought, I really think that's where we've got to be.
So was it one of those things that, so you're Kathy as well, is that right? Jenny. So Jenny, would you like to have a health assessment? Well, yeah, exactly. You're hardly selling it.
I think the term assessment, people worry they're going to either pass or fail.
Yeah.
I think that's
Yeah.
really bad.
So that's right. So we've got to look at the language, and we'll come to that in a moment because it is one of the biggest barriers to get people to come if you've got using the wrong language. Because when we think about what are older people interested in, that's right. So we need to be thinking about the language we use as practices to say, look, we've got a checkup for you to actually help keep you well at home. And we then need to understand what are the top 5 issues for older people. And we need to respond to those. And if basically their number 1 concern is, this is going to the 5 M's, what matters to them. And if we're not actually even asking what matters to them, because most of the time in our healthcare system, what's the matter with you is being asked, rather than number 1 thing, what matters to you? It's a very different framing of the questions. And a lot of work in the US through the Institute of Healthcare Improvement, which has put that at number 1 on the list of things to talk with older people about. What matters to them? Because you get a whole lot of issues coming out early on that if you go through a tick the box yes no questionnaire, you may never actually get to what matters to them. So it's a really important thing to put on number 1. We're here to understand what matters to you, and we're here to help you sort out what the issues are. Okay, so really important thing about older people, care plans for older people which need to be shared and are not just about single diseases. In my research, auditing practices and hospital case notes, I feel so sickened when I see my 88-year-old friends that have a care plan for diabetes, but none of the other 8 conditions are mentioned. And that's got to be an absolute gap that we can't allow to continue. Because again, if we all in this room care about older people, then we need to make a stand and say, if the standards in our practice are such that our care plans do not help older people, then we want nothing of that, because we're not delivering on what's required to be safe and effective. Because clearly all the older person is going to get is that they just think they're going to come and see you for their podiatry. Not much benefit in that, is there? Okay, now, going back to the evidence. So there's a lot of this, people are saying, 75 health assessments, not great, not doing what they need to do. But yet there's so much evidence for what's called the comprehensive geriatric assessment. Have you heard about this in the world of geriatricians and hospitals? The CGA. So much evidence that says this is what essentially makes a difference to older people with frailty. But guess what? It doesn't get done on every older person. It's focused on those that most need it. So basically, it's important because it identifies the geriatric syndromes, it looks at assessing functional performance and capacity, and it's used to monitor performance over time. Now, this little slide here is taken from, again, a friend of mine that was a geriatrician that helped me understand frailty. And this comes from, again, the BGS, British Geriatric Society, and the frailty approach. Now, before I go into this side, I want you to think about this side here, Mrs. Andrews. We want to avoid hospital for older people. We want to limit the healthcare related issues that might happen to an older person. Polypharmacy is a big one. We're all clever clinicians in this room. We see lots of older people. We're pretty good at thinking about this decline. I look at it this way. It's the trajectory of decline. Now, all of us have seen what happens to either our older relatives or our older patients. So because we've actually seen that, we can anticipate stuff that's going to happen, can't we? We're not mind readers, but people follow pretty similar paths. And so by anticipating problems, that's all about prevention, early intervention. Let's think about what might happen along the journey. And if we do, unless we anticipate, we're not going to be that helpful for people. And then we need to talk about the common record, the sharing of information. So the comprehensive geriatric assessment on this side is really good at doing this. And then it also, because it's not by itself, it also comes up with an individualised care plan for optimising a person's health and wellness, escalating if things get out of hand, and then there's an urgent plan, medication reviews, and of course the advanced care plan, which I'm sure, I think there's a couple of workshops on that over the last few days. So we need to be thinking about that in, does our 75 health assessment and the care plan for our older people actually match that? How many of you actually can hand on heart say that their health assessments and care plans for older people cover that? Okay, so what do you think about that as an opportunity for improvement? Too hard? No? No. And so again, if you go to the Fit for Frailty, it'll talk all about this and give you some ideas about what you can put into your current templates. Okay, so geriatric syndrome. So we need to be picking up things like, what's the continence like? And a little plug for my friends at one of the stands that about Continence Australia. How many of you have got their documents in your surgeries and waiting rooms? Okay, that should be something that's really important, because continence is often missed, even if we have a yes/no tick box. But if you ask about what matters to you, that is far more likely to come out. You know? And it might be that Mrs. Andrews, I'll just give you a little demonstration. So what matters to you, Mrs. Andrews? Oh, I'm just not getting out as much. Now, this is where you've got to keep asking why. So why, Mrs. Andrews, aren't you getting out as much? Oh, and often there's the, well, my legs aren't as good as they used to be. Well, why is that stopping you from getting out? Look, my bladder's not as good as it used to be, so if I get the urge to go to the toilet, my legs aren't working that well, I can't make it, and I'll have an embarrassing accident out in public. That's what's holding me back about socialising. It is crippling. So there's two things happening there that, you know, they might talk about their legs, but keep on asking the why. Why is this worrying you so much? And what's it not letting you do? And unlock those pieces of information. That will actually help yield so much about what needs to be done. Falls, frailty, dementia, delirium, depression, malnutrition, polypharmacy are all things that we need to be picking up better. Living with Frailty, Guide to Primary Care. This was a document put out in the UK, produced by the British Journal of Primary Care Nursing. Proud of that group of nurses. So it's something you can download, and it's got a whole lot of stuff about understanding frailty and that whole self-management discussion for older people. All right, so this is going back to Professor John Young. looking at what Mrs. Andrews, frail elderly, ending up presenting late in crisis, hospital-based care, all disruptive and disjointed. We need to change what we do. We need to think about an older person living with frailty as a long-term condition. Let's pick it up, timely identification, just like we would with diabetes and any other chronic condition. And then you can start putting it into a framework that can make it work for you as clinicians and the older person. So, we need to be focused. We need to be doing health assessments for those that most need them to actually deliver the value. So that's a list of people, and this ends up coming from the UK as well, where they just keep doing so much good research into community issues in older people. And essentially, this group are the ones that are going to actually benefit most. And here we are, recent ED and hospitalisation. How do you know that Mrs. Andrews has been in hospital? What was that? If you're lucky. So from a systems perspective, how does my practice know that 10 Mrs. Andrews have been in the local public hospital? For me then to proactively say to Kathy as nurse manager in my practice, Kathy, all those people that have been in ED this last month, could you make sure that they are visited at home, health assessments done, and let's put in place some proactive things. Has anyone got that system happening? No. So you need to work with your public hospitals to go, this is how, if we're truly going to have patient-centred medical homes, we need that information system to tell us what's happening so we can actually look at the data and find the people. Because currently, if I've got 10 doctors in my practice and there's 10 Mrs. Andrews, then how are we going to accumulate all that information and knowledge to actually get to Kathy for her to organise the system to actually do something different? It doesn't exist. It's all piecemeal. I'm lucky if Mrs. Andrews comes in with her ED letter, because in South Australia, where I'm from, EDs don't send them electronically or fax them. They actually give the older person the letter to come in, go and see Chris, and he'll sort you out. So we already know from the research that around about 40% of those letters are either not written or never arrive at the surgery. So information technology is required. It's a breakdown in communication, and I'm sure many of you also experience that. Okay, so here's also some really important research which backs up this, that the attendance of an older person at an ED is a sentinel event as a marker of functional decline. Now, what's a sentinel event in the world of safety and quality in healthcare? What was that? Red flag, that's right. And what happens if a sentinel event occurs in a hospital? Fantastic, thank you. Not only does she have a media unit, she knows about root cause analysis. That's really good. What was that? Oh, okay, right. So root cause analysis gets you to understand why did this happen, what can we do to prevent this ever happening again. You have to sit and be in the shoe, or walk in the shoes of the consumer to understand what happened to actually cause that event to occur and put in place something that changes that from happening again. We don't do it often enough. All right, so here's something from the Better Outcomes group that was released after reviewing primary care. So what works for complex care? All right, so targeting the population most likely to benefit, assessing the patient's health-related risks and needs, developing a proper care plan around their needs, engaging the person and their family in managing the care, connect people appropriately. And one of the things about why this is important and your role as primary healthcare nurses is your ability to recognise stuff and get people sorted and coordinated and referred in the right direction. How many of you in your practices have the autonomy to refer an older person to a service? Right, okay, so about a third of you have the autonomy. Now, something's got to change, doesn't it? Because essentially when we look at complex care, okay, Muggins here is the GP in the surgery. I can't do it all. I need a really good team around me. And I'm really happy to actually go, Kathy, you know, you're a really clever clinician, you know your stuff, you're seeing Mrs. Andrews, you've done an assessment, we've worked together, we know the template, we know that, all right, picking up frailty means it's a referral to the exercise physiology, the gym, the home exercise program, or, you know, in the practice we're running a home exercise class, we're going to teach people. That's the sort of stuff that our nursing workforce needs to be doing. Taking the initiative, being proactive, all right? I know I'm a little bit of a rarity because I'm really happy to work in teams. I'm happy to work shoulder to shoulder with other clinicians in complex care with this group of people, because I know the evidence says that's what makes a difference. If I do it on my own as a GP and actually say, just, you know, let me look at all these things and don't you refer anything, then we know, one, it won't get done. Two, the information will be lost. Three, I'll probably be focusing on the INR and the blood pressure because, you know, I'm burnt out and, you know, my interest in complexity is low. That's what tends to be happening these days. Complexity in care and GPs, the burnout rate is high. Their interest in doing the acute stuff only is what's going on. So complexity, all the successful industries, when we look at complexity, and those of you that who's read Atul Gawande and some of his checklist manifesto, learning from other industries how we deliver safe and effective whatever their industry is, means we have a checklist, we support people, we work in teams, and we communicate. That's what we've got to do in healthcare. We work with complex people like Mrs. Andrews. We're not seeing enough of it, and that's what we've got to lead change on in our practices. So, healthcare homes, patient-centred medical homes, what's happening? Got how many minutes, Kathy? 10? Okay, so here's our current practice. Anyone rings up, we see them. This is what we've got to do. We've got to be focused. We've got to actually look at risk stratification of our populations in our practice. We've got to know who really needs our care. Not just who can pick up the phone or use our online booking app. We need to target the care, target the population. How are we going to do that with older people? All right, that's from heart. That's just another pyramid. You'll be seeing a lot of pyramids, I think, in the next 12 months. Okay, and that's the pyramids of payment levels for healthcare homes. Anyway, we'll keep going. So this whole sort of concept of stratification and risk will be different in every practice. So what I've done here, and I want you to think about this when you look at your own data, these are a whole lot of practices that I've been working with. These are their active patients. This is their 75 plus population, and that's expressed as a percentage. So you can see the difference that some practices I've been working with only have 5% of their population is 75 and over. One practice is 23%, another one 18%. So what that means when we look at how many people are frail, because the 20% of people between 75 and 105 are frail. 20%, 1 in 5 of this group. And it increases the older they are. So these are the numbers then that could be. So let's look at this practice. 150 people in this practice could be frail. They are going to be your most complex group. They're going to be the ones that are in and out of hospital regularly. But based on the government's Tier 1 guesstimates, 1% of your practice population might actually be in this. So they're guessing that practice A might only have 45 people that would actually need to receive a payment for or enroll their patients. But based on this, 150 is more likely. So 4 times more than one would expect. So this is going to be really important when your practices, if and when they find out in the next few weeks. How many of your practices have put their hand up to be in a healthcare home? A few of you. Okay, so the future is coming though. So we need to understand what our population really looks like, what the burden of complexity could look like, and frailty is a great way of looking at this. Other ways of looking at it are using our data extraction tools. How many of you are PenCat whizzes using TopCat or other extraction tools? How many of you use it to find the people that really need their health assessments? Okay? And not just the fact they're 75. So what I'm going to show you here is a PenCat search for the people that are most likely to benefit from a health assessment, because they're the people that are most likely going to be frail. All right, basically, seen in the last 6 months, they take 8 or more medicines, they have a diagnosis of chronic kidney disease, and unfortunately our coding for that in our practices is not good, is it? 1 in 10 Australians, 1 in 3 people over 75 have chronic kidney disease. But it's not that well coded in your health summaries. Heart failure, COPD, again, another underperformer in our health summaries. Develop a report card and actually have a look at this. And then you can start drawing a line in the sand. Who really needs me to work hard at having a health assessment? So let's go back to the 5 M's, 3 D's, and 1 F. Okay, so basically why this is important. There's a lot of discussion now about shared decision making with older people. That's what they want. They don't want to be told, they want to be involved. There's a big difference. So you involve them in the care. Shared decision making is going to have a lot more reward than just telling them they need to do this or that or take this pill or you must go to this exercise class. So we need to think about involving them and thinking about, well, what makes a good day for you? It's a really interesting conversation starter with older people. And understanding what makes a good day comes up with a couple of things, is that I love getting out with my friends. I love going out to the bowls club. Oh, when was the last time you did that? Oh, about 9 months ago. What's stopping you from doing the thing you really like? The conversation then starts. My knee, I'm not as mobile, I need extra help, I can't drive anymore, continence, a whole raft of issues start coming out. So what matters to you and what makes a good day are really important discussions to start off your health assessments. Now, this is important too. All right, so basically, you know, we all talk about evidence-based care, but evidence-informed practice is probably greater for this group. Guideline medicine, single long-term condition, we can follow a rule book. Multiple long-term conditions and frailty, we need to actually have individualised care. We're not used to doing that because we've had guidelines thrust down our throat for so long. But what we've got to go back to for this group that have complex care needs is understand what they need and what they want and support them in achieving those things. It's a very different approach. Listening to the person, gather the information, share the information, that's our health assessment, setting goals with the person, having an action plan, agreeing and sharing. That's what GPMPs and TCAs are all about. Thanks, Kathy. Okay, so a couple of things as some take-homes. We need to be more effective with the use of time for the older person of practice because, as rubbed it off there, but we said before, time is always an issue. So how many of you actually do a health assessment and a care plan together? Good, okay. Now, a lot of people forget about that. And so some of the gaps are that if you don't do it, you often have different clinicians doing different parts of it, so there's a loss of continuity. The older person has to duplicate their story. The time it takes to actually work through it is actually increased. So it's far more effective from a practice time perspective to actually do it all in one go. It takes obviously longer than one, but it means that the older person doesn't have to come and see the practice twice. When you think about it from their perspective, the value that you have, why am I going back to see Chris again? Because it's a care plan, says the receptionist. So the receptionist isn't going to sell it that well, are they? So thinking about how you do it better and more effectively is important. And the other thing, how many of you use pre-visit surveys for your health assessments? Well, basically, where, with your really, articulate invitation to come along and have a checkup at the practice, you've actually put a evidence-based survey in to get an understanding about their wellness. They could actually fill out the PRISMA scorecard in advance. You could put some mood discussions in there about how they're feeling. You could put a whole lot of things. There's lots of these out there that they could fill in before they even get to see you. Yes? You do that? At home. Fantastic, one of you. But it's really, really good because it sets the agenda and also gets some of the work done so that you can focus on what you really need to focus on. Now, social history. How many of you include social history in every single bit of communication? Okay. No, not everyone, but really important because, and this is from the UK again, so in their software, all of these things are fields to fill out. Look at this: home, house, steps, apartment, number of levels, number of steps. What supports do you have? Caregiver stress. Look at advanced directive in place. Isn't that fantastic? That it's part of what, it's the culture, it's what they ask as part of the interaction with all people because it's important. And we think about this, social history in the context of what we do in primary health care is the fundamental part. Understanding a person's relationship to their environment and their social setting is what primary health care is all about. But the majority of people don't do it. They've lost that understanding. And our software, which should be smart to help us do the right thing, isn't helping us. Okay, so I talked about that. That's a checklist. Okay. Another guide, healthy ageing from the UK. Vaccinations again. So a lot of health assessments leave out the vaccination discussion. So great opportunity to discuss flu vax, pneumococcal, as well as the shingles vaccine. Right, so go back to, okay, mobility. All right, now this is just 1 minute to go. Okay. This is really important because it helps you anticipate. Now, here it is. 10 years ago, Mrs. Andrews said, I'm not as steady on my feet as I was 10 years ago. Then all of a sudden, 2 years ago, Dad or Mrs. Andrews is slowing down. A month ago, he's a fall waiting to happen. There's the trajectory of decline. Nothing was done. Nothing was done. He had to go to ED because that's what happened. We could have acted back here by going, I'm not as steady on my feet as I was. I'm slowing down in my walking. Let's get to the exercise program. Okay, and here's a really important thing. Okay, falls prevention. Physical activity in falls prevention is not a patient-centered message. Being active and staying steady is. Change the focus. Okay, and this comes from a marketing company I've been doing a bit of work with that have actually researched the messages that are effective for older people. Happy to share that with any of you afterwards, the whole article. Counting steps, Fitbit and Friends. Evidence is now saying that's actually a great way of engaging people with activity. Help, Active Aging Australia. Go to their website. They've got a program called Help Home Exercise Lifestyle Program because one of the negatives most practices say is older people don't want to pay for exercise programs. They've used their 5 visits already for podiatry, nothing left. So, help, you could run this in your practice. There's a great YouTube video of a nurse who has watched the video, there's a DVD, trained, helps skill the older people to do the exercises in their own home. And evidence has found that works. And the other part of the evidence is this bit here, is that you get a home exercise book, you've got an action plan, you've got the exercises in older person-friendly language that you can actually give them, you can copy it, and the Active Aging website tells you how you can get hold of those. There is a charge for it, but a really good resource for you, knowing that older people need far more than 5 visits, and I don't think it's going to change under the healthcare homes that they're going to get more than 5 visits. Now, Kathy's got the wind up here for me, so there's always plenty more we can talk about, but we're going to have to say that's enough today. We didn't get on to dementia, depression, other things, but you've had sessions on that in the past. But I wanted to really focus on recognising frailty. So F is for what? F is for fatigue. R is for resistance, getting up a flight of stairs, your body weight. A is for what? Ambulation, can you walk around the block? I is for illness, 5 or more. L is for loss of weight, 5% or more in the last 6 months. So really important, the frail screen. Go and see the Jane Winter. Put your hand up, Jane. And she'll talk to you more about the mini nutrition assessment. I didn't get onto that. There's a great app for that, for your iPhone. Look up MNA under the app and you can do some fantastic evidence-based nutrition assessment. It will help you so much more than just ticking boxes in your current nutritional assessments in your care plans, or health assessments. So thank you very much, everyone.
Thank you. Thank you so much, Chris. That was absolutely fantastic. We certainly got an awful lot out of that and a lot of take-home messages.
Polypharmacy we didn't get to talk about. That was one of the 5 M's. But clearly, if it's all getting too much, that frailty is complex, a referral to a geriatrician is really important because they can sort a lot of stuff out, but also a My Aged Care website referral. If you've identified frail, that will tick a whole lot of boxes in their referral, and they can actually respond to that and make available more resources. Even though we've got concerns about My Aged Care, but they will respond to frailty. Thank you.